This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation.
Today's case is...
This is a 47-year-old female who presents with myalgias and malaise for the past 24 hours. She feels like she is having chills and sweats, but has not been measuring her temperature at home.
Of note, through a social history, you obtained that the patient returned 3 days ago from an extended trip to Sierra Leone to see her family.
Her vital signs show that she is febrile with tachycardia. On exam, you note that she is diaphoretic and appears to not feel well. Aside from the tachycardia, she has a benign exam.
A sepsis workup is started, which includes labs, IV fluids, and antipyretics.
The lab looks at the patient's blood smear and calls you with concerns of a parasitic infection.
On re-questioning of the patient, you learn that she brought her malaria prophylaxis with her on the trip, but forgot to take it.
Mosquitoes can be quite the nuisance during certain times of the year due to their itch-inducing bites, but they can also be vectors for deadly diseases.
Since most emergency physicians do not ask about exposure to mosquito bites during their initial interaction with a patient, it is important to keep mosquito-borne infections in your differential in patients presenting with a viral syndrome.
Although some of these infections are not endemic to the United States, it is important to discuss a travel history with a patient because some endemic areas are a quick plane flight away.
Probably the most well-known of the mosquito-borne infections is malaria. It is endemic in Africa, as well as in Central, South America, and Asia. It caused 1.2 million deaths in 2010, most of which were in Africa.
Patients typically present with fever, headache, myalgias, chills, nausea, and vomiting. They can also have a cough.
Travelers to endemic countries are usually put on chemoprophylaxis, most commonly doxycycline or atovaquone. They are also reminded to wear pants and long-sleeve shirts, as well as to use bed nets and DEET containing repellents. Keep in mind that this is not 100% effective.
It is caused by a protozoa of the genus Plasmodium. There are 5 common species, which include Ovale, Vivax, Malariae, Nalesi, and Falciparum, with Falciparum being the most severe. It is transmitted by the Anopheles mosquito.
Cases are diagnosed based off of thick and thin Giemsa stains, which will show the parasite inside the red blood cells. The first smear is positive more than 90% of cases. If the first smear is negative, it takes performing smears twice per day for 3 days to completely exclude malaria.
Malaria patients can also have other lab abnormalities, including anemia, thrombocytopenia, elevated ESR and LDH, changes in their LFTs, acute kidney injury, hyponatremia, hypoglycemia, and interestingly, a false positive VDRL.
Disposition depends on severity of symptoms and species of the Plasmodium. All patients with confirmed Falciparum or Nalesi species should be admitted. Young children, pregnant patients, and immunocompromised patients should also be admitted.
Anyone displaying signs or symptoms of a severe infection should be admitted and consider ICU admission for cerebral malaria causing altered mental status or seizures.
Treatment for malaria depends on several factors and the recommendations are constantly changing. Choice of treatment should be made in conjunction with your hospital's infectious disease specialist or with the professionals at the CDC on the malaria hotline.
The CDC website also has a PDF file that is kept up to date. A link is provided in the description of this video to access the file.
The next 3 diseases are endemic to the Americas and are transmitted by the Aedes mosquito. All have very similar presentations and are difficult to distinguish from the others.
Dengue fever, also known as breakback fever due to the amount of pain that happens, is caused by a flavivirus. Patients usually have a viral syndrome with GI symptoms and rash. They can also have bleeding from the mucosa and skin.
Severe dengue can cause plasma leakage and shock. Patients will also have hypoproteinemia, hemoconcentration, and can have pleural effusions and ascites.
Interestingly, they may display Faget's sign, also known as pulse temperature dissociation or sphygmothermic dissociation. Usually fevers cause a tachycardia. However, dengue patients can display a relative bradycardia for how high their temperature is.
Labs will show leukopenia and thrombocytopenia and potentially elevated liver enzymes.
A tourniquet test can be attempted. This is performed by inflating a blood pressure cuff on the arm, which results in petechia. It tests for capillary fragility. Although not very sensitive alone, it is 94% sensitive for dengue in the setting of leukopenia.
Treatment is supportive using IV fluids and avoiding aspirin and NSAIDs in the setting of hemorrhage.
Chikungunya and Zika are also contracted through the Aedes mosquito and can have similar presentations. Both cause a viral syndrome presenting with myalgias, polyarthralgias, rash, and potentially fevers.
Typically, chikungunya patients have acute onset of bilateral migratory arthralgias that affects the small joints and varies in severity from mildly irritating to completely incapacitating. It is also commonly associated with GI symptoms and high-grade fever.
Zika, on the other hand, is more commonly associated with low-grade fever, exudative conjunctivitis, and a headache. Neutropenia can be seen on CBC for chikungunya, while lymphopenia is more common with Zika.
Diagnosis is largely clinical. However, due to possible complications including Guillain-Barré's, meningeal encephalitis, and fetal defects, confirmatory testing is recommended via immunoassays and PCR.
Care for these patients is symptomatic with pain medication and fluids. Avoid NSAIDs until dengue fever is ruled out.
The fear complication in pregnant patients with Zika is microcephaly in their future child. Women of childbearing age, especially if pregnant, should avoid Zika endemic areas or be especially careful to avoid mosquito bites. Keep in mind that more than 80% of patients infected with Zika are asymptomatic.
Men should use contraception if they have recently traveled to an endemic area and have a pregnant partner.
Refer pregnant patients to a maternal fetal medicine specialist if there's a chance that they could have been exposed.
Yellow fever is also a flavivirus related to that which causes dengue. It is also carried by the Aedes mosquito, but is not endemic to the United States.
Patients present with a viral syndrome. However, it can progress to liver disease, renal failure, injury to the heart, and bleeding complications. It is imperative to check labs in these individuals to rule out these complications. Just like dengue, patients can exhibit Faget's sign as well.
Treatment is symptomatic. There is a vaccination against yellow fever, so recommend this to all patients traveling to endemic areas.
Viral encephalitis can also be caused by mosquito vector. These include West Nile, St. Louis, La Crosse, and the equines. These are arboviruses.
Patients typically present with fever, headache, meningeal signs, cognitive defects, and movement disorders. They can also present as seizures.
Interestingly, St. Louis encephalitis can have dysuria and pyuria. West Nile typically presents with extreme lethargy.
All will require a lumbar puncture. There is typically a pleocytosis with dominance of the lymphocytes and protein elevation. Most have PCR tests available for confirmation. Treatment is supportive care and admission to the hospital.
To summarize, make sure to ask about travel in all patients when appropriate. Some diseases are not endemic in your area and could be missed if you do not know where the patient has been.
Some of the mosquito-borne diseases have vaccinations and prophylaxis, so don't forget to recommend these to your traveling patients. Also, don't forget to mention ways to avoid mosquito bites.
Not all patients with myalgias and fevers are just viral syndromes. Make sure to think outside of the box.
Be cautious in pregnant patients who have traveled to Zika endemic areas and refer them to a high-risk pregnancy obstetrician if warranted.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.